Well, thank you very much for inviting me to speak today. Um, just trying to move my slides on. There we go. So in this session, we're going to be covering briefly the long-term complications of COVID-19 and particularly focusing on autonomic dysfunction. Dr. Amy Small is going to describe her journey as a patient. We'll then talk a little bit about the pathophysiology, diagnosis and management of postural tachycardia syndrome, some of the comorbid conditions in non-COVID PoTS, and then Anita Kiernan will talk about the impact of having a diagnosis, particularly in relation to adjustments at work, and then hopefully we'll have time for a little questions at the end. So as you all know, COVID-19 is a multi-system infection, and it can affect ENT, it can affect skins, causing rashes, muscles, joints, causes acute kidney injury, mental health issues, gut problems, and the more sort of the ones with a higher mortality, respiratory, cardiac, in particular myocarditis and pericarditis, and the vascular complications such as stroke, encephalopathy, microvascular disease, including microvascular angina and COVID-TOS, coagulation disorders such as DVT and pulmonary embolism, and then neurovascular problems. And today we're going to particularly focus on the autonomic nervous system. And by March of this year, there have been 445 million cases of COVID-19 that have been documented. And this has led to just under 6 million deaths. Of the patients that have been infected, as you know, many fully recover. Some develop specific end organ damage, and that may need to be dealt with in a single organ specialty. And then many patients go on and develop long COVID. The statistics vary, but in the region of about 10%. So I thought it would be useful to start with definitions, and these were developed by NICE in association with SIGN, the Scottish version of NICE, and the Royal College of GPs. And I think this was the first collaboration. And in December, just over a year ago, they developed the first long COVID guidance. It's evidence-based as much as it can be in a new condition, and they also had to rely on expert recommendations. It was developed by an independent committee of healthcare professionals, and there were also a number of lay people who were long COVID patients on the committee, and there were consultations with stakeholders as well. So acute COVID-19 is signs and symptoms up to 4 weeks. Ongoing symptomatic COVID-19 is signs and symptoms from 4 to 12 weeks, and post-COVID-19 is signs and symptoms after COVID-19 infection that continue for more than 12 weeks and are not explained by an alternative diagnosis. The two ongoing symptomatic and post-COVID were mainly developed for research purposes. And then long COVID, of course, is the patient-derived term, and that includes ongoing symptomatic and post-COVID-19. So like acute COVID, long COVID can affect pretty much every system in the body, and I think Amy's going to talk a little bit more about that in her talk. So these are the statistics from the Office of National Statistics and published just a few days ago in March 2022, discussing the impact of long COVID on patients in the UK. And by by the end of January, an estimated 1.5 million people in private households in the UK were reporting long-term symptoms of COVID, and that equates to 2.4% of the population. The long COVID is impacting on the activities of daily living of 65% of these patients in a significant way, and over 250,000 people are severely affected. Almost half of the patients have had symptoms for over a year, and the commonest ones are fatigue, loss of sense of smell, breathlessness, and brain fog. It most commonly affects women aged 35 to 49, although there has been a recent surge in children. It's more common in socially deprived areas, and it's more common in health and social care workers and workers in education, and in people who have pre-existing activity limiting health conditions. And of those who worked before COVID, about a fifth are no longer working, and about a fifth have had to change their occupational status, often reducing to part-time. So what is the relationship between PoTS and long COVID? Well, in a very recently published paper from UCLH in London, where they had one of the earliest long COVID clinics and one of the larger long COVID clinics, and they reported that they found that 13% of their non-hospitalized long COVID patients were developing postural symptoms. And by that, I mean things like lightheadedness or palpitations on standing. And these postural symptoms were strongly associated with a poorer health status. And of these patients with postural symptoms, about half of them have been found to have PoTS. Now, of course, not all orthostatic intolerance in long COVID is due to PoTS. You sometimes find, orthostatic intolerance being the development of symptoms in the upright position that are relieved by lying down. And this can be caused in long COVID by orthostatic hypertension, although that's less common. It can be caused by vasovagal syncope. PoTS is the most common cause. And then there's a significant number of patients who have reproducible orthostatic symptoms, but when you test them with a stand test, they don't test positive for either PoTS or orthostatic hypertension. And there are very early indications that long COVID PoTS mirrors non-COVID PoTS in symptomatology, and the same management's being used. And in fact, when NICE first developed the long COVID guidance, they recommended that in patients who have symptoms of orthostatic intolerance, they should have an active stand test. And that should ideally be for 3 minutes if you're looking for orthostatic hypertension, and 10 minutes when you're looking for PoTS. So there have been a number of publications looking at PoTS in long COVID. They started off with a few individual case reports and have moved on to some small case series. However, there are some issues with these studies in that they're often retrospective. They have very small numbers, and often they have few or even no control populations. And they're usually a very selected cohort of patients, in that all these studies are often being done in autonomic clinics or in PoTS clinics, for example. And many of the patients have a clinical diagnosis of COVID-19 because the testing wasn't available at the time when they had their acute infection. We're finding that people are using different testing and different diagnostic criteria, so you can't really compare the studies, and all the studies have been done in adults. There's very little in children, and again there's very little in the way of follow-up of these patients to understand what the long-term or even sort of longer short-term outcomes are. I haven't got time to go into detail, but this is just a sample of a few of the studies looking at PoTS in long COVID. And I just want to highlight a few issues from these studies. So Novak and company, they compared long COVID patients to non-COVID PoTS patients and controls. And they found that almost 80% of long COVID patients had evidence of small fibre neuropathy on their skin biopsies, and half of COVID patients, PoTS patients had this, and none of the controls. And they also found that long COVID patients and PoTS patients had a significantly reduced cerebral blood flow when they were upright, and the control patients didn't. And the studies generally found that the patients didn't respond so well to the lifestyle changes that are often recommended as part of the PoTS management strategies, and many needed to go on to medication, although we don't really know how this compares with the non-COVID PoTS population. There were a couple of studies from Dublin that didn't find any PoTS in their long COVID patients, but they were looking at a much older patient population. It was based in a falls and syncope clinic run by Medicine for the Elderly consultants, and they also ruled out any patients, excluded them if they experienced syncope, which would have probably excluded a lot of the PoTS patients. They also tested them on treatment for PoTS such as beta blockers, so it's difficult to know how to interpret their results. But general observations have been that people who have PoTS in the long COVID setting are mostly younger women. They're often non-hospitalised patients. They often have marked cardiac symptoms such as palpitations, chest pain and breathlessness. Generally speaking, however, the cardiac tests are normal. But having said that, it's very important to rule out cardiac conditions when you're presented with patients with these symptoms. Usually patients are treated with lifestyle measures first, and then the usual medication for PoTS, which we'll come on to later. And it's been noted that very often patients have minor autonomic symptoms before they had their acute COVID-19 infection. And it sort of raised the question that do these patients have a predisposition to these autonomic disorders? And it's a bit like a loaded gun, and then the COVID-19 is like pulling the trigger that fires it and sets off the more florid PoTS. So on that note, I would like to introduce Dr. Amy Small. Amy is a GP in Lothian who has been living with long COVID, and she's going to tell you her story.
Thanks, Leslie. I will just get my slides up. Here we go. So yes, I'm Amy Small, I'm a GP in Lothian, and I'm also clinical advisor to Chest, Heart and Stroke Scotland, which is a charity that provides telephone support for patients living with long COVID, managing their breathlessness and fatigue management in particular. So just to sort of put a bit of background, this was me prior to COVID. I very sort of fit the bill very well of what Leslie said. I was 39 when I got sick. This photo of me with a marathon medal is a complete cheat. I did not run a marathon, but it was a 10K. I was someone who was fit and healthy. I regularly ran 5K several times a week. This is a photo of my boys, who were 3 and 5 at the time when we got sick with COVID, up Blackford Hill on one of our many daily walks that we did during lockdown. I was a 5-session partner in a practice in East Lothian, and in my spare time I did a lot of BMA activity work, which has set me up quite well to have a platform to advocate for people living with long COVID. Now, so to tell you my journey, I got sick on April 11th, typical COVID symptoms. I had a headache on the first day, a bit of fever, and it came on quite insidiously. And the only thing that I would say was quite different from sort of flu was A, the insidious onset rather than the hit by a bus type thing that you get with the flu, and B was the breathlessness. I'd never experienced anything like it, and that was really from the get-go. I had also associated symptoms of vertigo. My oxygen sats were dropping to about 86, 87%, and had all the other typical myalgia, tachycardia, other symptoms that went along with it. And because it was the first wave and because we were told to stay at home, we did stay at home. When you think back now, any fit and healthy 39-year-old with oxygen stats of 87, you probably wouldn't have kept them at home, but that's what we did. And we did, and we stayed at home and we just got on with it. 2 weeks into my illness, my temperature was going up rather than down. I ended up phoning 111 and I was assessed at the COVID assessment centre, and the nurse said, well, your examination's normal, but you can have some doxycycline if you want, and maybe there's an underlying bacterial infection, and see how you go. So I took it to see if it would help, and of course it didn't. 3 weeks in, I was getting more breathless. I had a respirate of 30 for the whole day, and I was beginning to panic. I'd been reading about people getting PEs and DVTs and stuff, and I thought, gosh, maybe I've got a PE now. So I phoned 111 and I was seen up at the acute medical assessment unit, where they did various bloods, including a D-dimer and chest x-ray and the whole shebang. And they said, look, there's nothing that we can find. Go home and rest. And I had fever every day at this point. I hadn't had a respite with that. I was still breathless. I was still, all the stuff that I've listed at the top was all still going on. 4 weeks in, I still was febrile. I still wasn't getting any better, but I was going stir crazy at home. And so I contacted an infectious diseases colleague and said, if I go out, am I going to be Typhoid Mary and infect everyone, or am I safe because I still have fever? And he said, you're not going to infect anyone, but we need to see you because it's not normal that you still have fever 4 weeks into this illness. So I got referred by my GP, and so I was seen by them, and they did all sorts of wonderful random serum rhubarbs and more testing and all the rest of it, and told me that everything was normal. All I had was a very mildly raised CRP of 18, and that was it. So they said, go home and rest, and we'll call you in 3 months and see how you are. So that was that. I went home, desperately trying to look after a 3 and a 5-year-old. My husband also has long COVID. So that was fun. Using Disney Plus as our surrogate parenting. As you know, we couldn't have anyone to help us because it was COVID, it was lockdown, and no one else wanted to get sick. I remember trying to brush my kids' teeth, having to hold one hand with the other. I mean, I'd never experienced anything like that in my life. Just every last bit of energy had been drained from my body. So come June, I tried to work. I stupidly said to myself, oh, this must all be in your head, and if you go back to work, you'll be fine, and just pick yourself up and get on with it. I was feeling terribly guilty. You know, there I was, a GP during a pandemic, not working, and my colleagues were having to pick up the slack. Oc Health weren't interested because I was still febrile. So I spoke to my partners and we suggested that maybe I did a two-day-a-week slow phased return. And that one day of clinical face-to-face work triggered the most almighty relapse, and that's when I realized that cognitive fatigue or cognitive strain could cause physical fatigue like I'd never experienced. I was in bed for 10 days. I couldn't speak one day because my muscles in my face were so fatigued that it was too tiring to verbalize, to use my tongue or anything. I could hardly drink. I could hardly lift my hand to my mouth. I couldn't eat because chewing hurt. Chewing cereal hurt my jaw. And at that point, I totally freaked out and thought, that's it, I've got ME, and this is going to be me. This is the rest of my life. So I contacted a friend who, non-medic, who had ME, and I asked her what she had found was helpful for her. And she had suggested that I look at seeing a nutritionist, cut out sugar, which did actually help when it came to fatigue. That did help. She suggested I see an osteopath. That was helpful because the osteopath told me I didn't have ME, so that was great. I don't know how much the rest of it helped, but that was really reassuring. I took to Twitter, and lots of people in there had suggested that I learn about pacing. And I found a wonderful book for people living with ME, and learnt how to pace. So over the summer, it was becoming apparent that I was likely to lose my job. We had a 6-month cut-off clause in our partnership agreement. I was at that point was having lots of investigations. I'd been seen again by ID, who was surprised that I still had fever. Some 5 months in, they were shocked that I was still having daily fever. And I had a CT chest abdo pelvis, I had an echo, I had lung function tests, I had a 24-hour tape, and the only thing came back as abnormal was that I was persistently tachycardic. And I'd started to pay attention to my Fitbit at this point, and I noticed that whenever I stood up, my heart rate kept going up, and when I brushed my teeth, my heart rate was 110, and my resting heart rate was 58, and I thought, that's a bit odd, you know, that shouldn't be happening. When I walked up the stairs, my heart rate was 145, and I had to stop halfway up every single day. And I've got 2 flights of stairs in my house, and the kids always forgetting things upstairs that they needed, etc. So I was beginning to see that there was a bit of a pattern there. And it was during the last meeting with my partners that I was nervous about, that I had some out-of-date propranolol from when my father was dying. And I thought, I'm just going to take the propranolol to get me through the meeting. Maybe it'll help. And it was at that point that I started to feel better. And I thought, gosh, you know, I'd been reading about PoTS, I'd been hearing about dysautonomia. I was putting 2 and 2 together and seeing, you know, persistent fever, persistent breathlessness, persistent tachycardia. Was this PoTS? Is this what I had? So I phoned up my GP and I said, I wonder if I've got PoTS. And she was great, and we discussed it. And she said, well, why don't we try some bisoprolol and see if it helps? I had tried the sort of the basic fluids and things, but this was at a point I was losing my job and I needed something to help me quickly to kind of see if I could get better more quickly. And that made a huge difference to me. But within about 2 weeks of starting bisoprolol, I felt so much better. I could keep up with my then 4-year-old. I could walk alongside him. I hadn't been able to do that for months, and he was really, really slow. I could walk up the stairs without stopping. And I started then in November, about 2 weeks after I had the cutoff date for my job. I started locuming again, and I managed to do a phase return with the help of supportive colleagues around me. So by January, I was working full-time at a mix of locum and portfolio. So yes, I had to change my career quite significantly. And at this point, I'd noticed that the bisoprolol that I'd been on had made me been feeling quite low. And I think it's important to remember that beta blockers can make you feel depressed as well. And it was different from the other sort of anxiety type or mood issues that I had related to the whole situation. So I'd had a chat with my GP and asked if I could possibly switch to ivabradine. And she emailed the cardiologist to get some advice because she'd not come across it before. And they were happy to support her in prescribing that. So I'd sort of titrated my doses. I played around with it a bit. I'd been hearing that Dr. Gall said you could go up to 5 milligrams TDS, and I sort of messed around to see what worked for me. And so I was taking 5 milligrams BD, seemed to work for me. By Easter, I was able to walk 15,000 steps a day without post-exertional malaise. And by the summer, I started to do the couch to 5K. I could then exercise regularly without feeling horrendous and breathless. And I was managing with the aid of fluids to support that. So by the end of the summer, I started to come off my medication. I weaned down 2.5 BD and managed to exercise 5 times a week, and really felt that I'd recovered fully and was quite excited about that. In September, I had a booster, and that caused a massive relapse. And my temperatures went back up. I was tachycardic again, I was breathless again, I was fatigued again. So I started back on the medication, and I still remain on that now. I haven't quite got back to where I feel like I can come off it yet, but I am ever hopeful as I start to get better and back into exercise again. And in January, I got COVID again. Of course, the kids brought it home from school, and I felt horrendous again for a few days and freaked out and thought, God, it's all coming back. But I managed to get on the panoramic trial and get some molnupiravir, and that 2 doses of that, and I was feeling so much better, which was a real relief. So I guess that's just my story. And I think in all of this, it's made me realize, probably how many cases of PoTS I've missed over the years. When we think about the number of young women we see as GPs who are breathless, tachycardic, chest pains, our instinct is to go immediately to anxiety. And the number of patients I've seen since I've had this that have been treated with SSRIs and things over the phone that have never been examined. And if there's one message I would get out to my colleagues, is see these people, see them face to face, examine them, because you don't know what you might find. Yeah, it's been a really interesting journey, and I've learned so much from it. And hopefully you can learn more here today. Thank you.
Thank you, Amy, for that really excellent and very insightful description of living with COVID. So thank you very much for sharing that with us. I'm just going to talk now a little bit about PoTS in general, and a lot of what I'll say is actually relevant to orthostatic hypotension and vasovagal syncope as well. Okay, so I just want to first of all describe a little bit about the pathophysiology of PoTS. So what happens when a healthy person stands up? That's the image on the left. Well, initially there's a drop from the thorax of between about 500 mils and a litre of blood into the abdominal cavity and limbs. But there's immediate vasoconstriction, which sends the blood back up to the heart and onto the brain. But in PoTS and in some people with vasovagal syncope and orthostatic hypertension, this mechanism doesn't work properly. And this results in pooling of blood in the abdominal cavity and limbs, with reduced venous return to the heart and reduced onward blood supply to the brain. There's also a compensatory tachycardia, and excess adrenaline is released in an attempt to maintain the blood pressure. There's a lot of crossover between all the different syndromes of orthostatic intolerance. Patients with vasovagal syncope tend to be quite well in between episodes, whereas patients with PoTS and orthostatic hypertension tend to be more chronically unwell. And in fact, many patients develop symptoms every time they stand up, and in some severely affected patients, every time they sit up, they can start to develop symptoms. This inadequate vasoconstriction results in a relative hypovolemia. In other words, the blood volume is reduced in relation to the excessive capacity of the blood vessels. And this results in these typical symptoms. The three commonest in PoTS are lightheadedness, fatigue, and palpitations. Patients also develop sweating, shakiness, visual and hearing disturbances such as visual graying. They become quite pale in colour. In the UK, about 60% of patients with PoTS report recurrent syncope, which is a bit higher, for example, than in the USA. I do wonder if that's because you have to experience syncope to end up in the right clinic for someone to recognise your PoTS. In addition, difficulty in thinking is very common, or brain fog, and patients often find this the most disabling of all the symptoms. So how do you diagnose PoTS? Well, the key, as with many things in medicine, is taking a detailed history and particularly identifying these symptoms of orthostatic intolerance. On examination, when patients stand up, they often, 50% of PoTS patients, in fact, reveal acrocyanosis, which is this sort of puffy, purpley colour of dependent arms and hands and feet. And in fact, it can go up to the knees as well. And you can see it in this picture here. The right foot has been dependent, the left one elevated, and they've just been put together for taking the photograph. You will almost certainly want to do some blood tests depending on the symptoms, and it might include Usinase, full blood count, iron levels, thyroid function, and a morning cortisol. Again, you should do an ECG because patients are often having palpitations and breathlessness. And then other investigations as indicated, and particularly in the long COVID setting, where patients are describing these cardiac symptoms, if they're available to you, then you might want to do a 24-hour Holter monitor, echo, and through cardiology, patients may also have a cardiac MRI to exclude myocarditis, pericarditis, and sometimes troponin and D-dimers are useful. The gold standard test is a 10-minute active stand test. And to do that, you would normally lie your patient down until they're settled and then do their heart rate and blood pressure. stand them up. I usually stand them up in my surgery against a wall or in front of a chair or a bed, because occasionally patients do faint and it's much easier to manage that situation that way. And then you would do heart rate and blood pressure immediately on standing, and then every 1 to 2 minutes for 10 minutes, keeping a very close eye on the patient and asking them about their symptoms as you go. If there's any doubt about the diagnosis, then it may be necessary to refer the patient for a tilt table test. And this is what a tilt table test printout looks like. And you can see here in the control that when the patient is tilted head up to about 60 to 70 degrees, you can see that their heart rate goes up a little bit. It's normal to go up 10 to 20 beats per minute. And the blood pressure here remains relatively stable. In the PoTS patient, when they're tilted head up, you can see that the heart rate rockets up to, in this case, about 180, 190 beats per minute, but it doesn't have to be as much as that. And then very characteristically, the blood pressure becomes quite unstable. And in fact, the definition of PoTS is, and this is important, frequent symptoms of PoTS on standing, associated with an increase in heart rate of 30 beats per minute, which should be persistent. Children have a higher normal increase in their heart rate, and therefore for teenagers, you need 40 beats per minute increase in heart rate. And there should be no drop in blood pressure, but in fact, PoTS and vasovagal syncope can coexist, and so patients can have a PoTS response, and then they can later go on and develop a vasovagal response with a drop in heart rate and blood pressure. So I've been asked to talk a little bit about the non-COVID sort of comorbid conditions in postural tachycardia syndrome. I'm going to very briefly cover the hypermobile form of Ehlers-Danlos syndrome, which is often mistaken for fibromyalgia, a little bit about chronic fatigue syndrome and mast cell activation syndrome, which interestingly seems to be appearing in long COVID, even in patients who don't have PoTS. And then just to briefly mention that autoimmune conditions are more common in PoTS, and in fact, Sjogren's specifically has been identified as a likely causative agent, and in fact you can treat the Sjogren's with immunosuppressants and the PoTS can get better. And there's also been a number of case reports in relation to Lyme disease. So the hypermobile form of Ehlers-Danlos and the hypermobility spectrum disorders are inherited connective tissue disorders. In fact, it's autosomal dominant, and the patients, in addition to having hypermobile joints, often experience fatigue, irritable bowel syndrome like symptoms, allergies, mast cell activation, chronic pain. They often have a weak pelvic floor, so they have stress incontinence but not had children. Migraine is common, poor sleep and anxiety. Skin is characteristically quite stretchy and bruises easily, and you get abnormal scarring in these patients. And then low blood pressure on standing is very common, and PoTS occurs in about 15% of patients, but in reverse, we often find that around 50% of our PoTS patients have hypermobility. And in practice, I often identify these patients from the patients who have medically unexplained symptoms. You often find that in hypermobile EDS, if you look at their notes, they've got really thick notes or very extensive notes, but no clear diagnosis. And I often find that patients have been to a rheumatology clinic with their joint pains and come out with a diagnosis of arthropathy of unknown cause. They've often been through gastroenterology, and they've been diagnosed with severe irritable bowel syndrome. And then they've often been through a cardiology clinic with syncope or palpitations, and they've quite often been to ENT with their lightheadedness, and the connection's not always made with standing. So in chronic fatigue syndrome, depending on the testing that's used and the paper you read, between about 8 and about 28% of patients have PoTS. In fact, many patients with CSF have orthostatic intolerance, and quite a lot have low blood pressure as well, and that can be managed in the normal way. And in fact, in the most recent edition of the ME/CSF guideline produced in October 21, a new recommendation is that patients with ME/CSF that experience symptoms of orthostatic intolerance should have an active stand test, should be tested for these conditions. And then mast cell activation syndrome. This is a recently recognised condition where patients, it's not that they have too many mast cells as they do in mastocytosis, it's just that they release their contents inappropriately and can cause lots of allergic type reactions such as skin rashes, urticaria, even recurrent anaphylaxis, but it causes a lot more systemic symptoms as well, such as gut problems and bowel problems. It's quite difficult to test for MCAS, and very often patients end up being treated empirically with antihistamines and mast cell stabilizers. And as I mentioned before, there has been some discussion about mast cell activation in long COVID, and I do hear of reports of patients finding that their symptoms are responding to antihistamine therapy. So how do you treat PoTS? Well, much of the treatment has been hijacked from that of orthostatic hypotension, and many of the treatments are helpful in vasovagal syncope as well. So first of all, you want to avoid triggers, that's drugs that lower blood pressure or increase heart rate. So you want to review the need for these and see whether you can stop them. You want to recommend the patient avoids prolonged standing, or in some patients, they can even develop symptoms with prolonged sitting. Heat and alcohol are vasodilators and should be avoided where possible, and heavy meals rich in refined carbohydrates can trigger symptoms as well. Take a detailed fluid history, because we often find that patients are not drinking as much as they think they are, and we would recommend a minimum of 2 to 3 litres a day in an adult, and in children they should drink until their urine runs a pale straw colour. We'd also recommend a boost before rising, because patients are more symptomatic because you're a bit dehydrated overnight. And rapid water drinking in an emergency is helpful. That's where you drink a couple of glasses of tepid water in quick succession, and within 2 to 3 minutes, that will elevate the blood pressure due to a sympathetic reflex. Unless it's contraindicated, we would recommend an extra 6 grams of salt a day, and that's equivalent to a level teaspoon of salt, or 10 slow sodium tablets, and that helps to expand the blood volume. And in children, you've got to be particularly cautious because of their smaller size, and they're very sensitive to extra salt intake. We often find that patients benefit from a diet that is low in refined carbohydrates, and they tend to eat small meals often, maybe eating half as much, but 6 small meals a day. There have been a lot of other diets that you find that patients report being helpful, but there hasn't really been very much research into these at the moment. Often exercise is recommended in PoTS. It has actually been suggested that deconditioning is the cause of PoTS, but in our study at PoTS UK a few years ago, we found that the majority of patients were very active and taking regular exercise, like Amy, just before they were hit by their PoTS. And some patients can develop symptoms overnight. So we think it's more a compounding problem rather than a cause. Unfortunately, exercise can cause patients to be completely wiped out for hours or sometimes even days afterwards. So you have to be very cautious with exercise therapy, starting very often at a low level and increasing gradually telling the patient that it's going to take between 6 weeks and 3 months to make a difference, and they might feel worse beforehand. It's useful to start with horizontal exercise such as Pilates and swimming, moving on to recumbent biking, and then graduating onto upright exercise such as brisk walking. There are other self-management techniques. As mentioned before, pacing can be very important to some patients. Postural maneuvers such as activating the skeletal muscles by tightening the thighs, clenching the fists and buttocks together can raise your blood pressure and lower your heart rate. In orthostatic hypertension, raising the head end of the bed is useful. I wouldn't recommend doing it as in the image on the slide, but a couple of bricks under the head end can be useful. There isn't any evidence yet for use of this in PoTS. And then compression clothing is also useful, both in PoTS and orthostatic hypertension, and we would normally recommend it to be waist high to help with abdominal compression as well. If lifestyle changes don't help, or in severely ill patients, sometimes it's necessary to start medication at an earlier stage. And as mentioned before, you will want to remove drugs where possible that trigger symptoms, and then add medication that either improves the blood volume, narrows blood vessels, or blunts the tachycardia. And so in PoTS, we use, as Amy mentioned, beta blockers, and ivabradine is really useful because it doesn't have the same tendency to lower the blood pressure as beta blockers do. And then midodrine is also quite commonly used, fludrocortisone, which expands the blood volume, and midodrine narrows blood vessels, pyridostigmine, and desmopressin is sometimes used as a sort of pill in the pocket type medication because of its risk of hyponatremia. So patients would just take one tablet if they know they're going to have a particularly difficult day, for example, exams or their wedding or something like that, and that helps to, again, expand their blood volume.